Hi, greetings. This is Dr. Deepak Megur. He is an elderly male patient who has Phacolytic glaucoma and is presented with severe raised pressure and pain, and he has not been seeing well in this eye for some time now. So at presentation, the pressures were extremely high, and the patient was on medical treatment for control of intraocular pressure and the inflammation for a couple of days before he was posted for surgery. On the day of the surgery, IV mannitol was given just an hour before taking him up for surgery. The plan is to do a manual small incision cataract surgery, as I'm expecting weak zonules in this eye. Apart from hypermature Morgagnian cataract, the eye also has pseudoexfoliation. 1.5 ml of lignocaine in the posterior subtenon space is given. Subconjunctival lignocaine is used to balloon up the conjunctiva near the incision site. Conjunctival flap is raised. Mild cautery to the bleeders is applied. Time to create the scleral tunnel. 1.5 mm from the limbus, an external scleral groove is created, and then the scleral tunneling is started using a crescent knife. Care is taken to ensure that the corneal end of the tunnel is at least 1.5 mm to the limbus through the span of the sclerocorneal tunnel. We have a tunnel which is measuring about 6.5 mm in width. Side port incisions are created. There is a little bit of issue for the space. We have a pigmented lesion on the limbus on one side and a pterygium on the other side. Nevertheless, I could squeeze in two side ports on either side. The capsule is stained. OVD is placed into the eye. I'm also placing OVD in the tunnel area so that I can delineate the inner lip. Using a 2.8 mm sharp keratome, the internal entry is created and it's extended on either side. OVD is replaced into the eye to pressurize the anterior chamber. I'm using the Haldipoka forceps to perforate the intracapsule, and we can see these wrinkles in the intracapsule suggesting extreme zonular weakness. Nevertheless, I could perforate the anticapsule, raise a flap, and I'm trying to tear the capsule. The pupil is around 4.5 mm. I'm trying to make a slightly bigger axis, and I'm trying to go beyond the pupil, and this was an error. And as I'm going to the periphery, you can see that I can feel that I'm losing the bag. The zonules are extremely weak, and at this point I feel that the axis is already run towards the equator. The anticapsule gets stuck in the forceps, and as I'm moving it out of the eye, the entire bag just prolapses out. So I think this is the capsule which is beyond the equator, has come and lying anterior to the nucleus. So it was clear that there is no point in attempting to salvage the bag. The bag is almost out now. So using viscoexpression, I just deliver out the small Morgagnian nucleus out, and then using a forceps, just remove all the capsular bag remnants. So now I've had an inadvertent intracapsular extraction in this Phacolytic glaucoma because of the loose zonules. And at this stage, the anterior hyaloid seems to be intact and there's no evidence of vitreous prolapse. So I thought I can just go ahead and do an iris claw lens implantation. Before that, I'm going to do an iridectomy. So when we have a sclerocorneal tunnel, it's difficult to do an iridectomy using a scissors and a forceps, especially in the superior quadrant. Usually I use the vitrector to do an iridectomy, but because I have not opened the vitrector still as the anterior hyaloid seems to be intact, I'm going in with the scissors and a forceps. I have a micro scissors in my left hand and a forceps in my right hand. The peripheral iris in the inferior quadrant is lifted and a small snip is given to have a small iridectomy in the peripheral area. Now is the time to implant the iris claw lens. So again, the OVD is used to inflate the chamber. The lens is introduced into the eye. The problem here is that we haven't planned the incisions in the right area so that they can match the area of the iris claw. Because of the presence of a pterygium and the pigmented lesion on the limbus, I have fashioned both the side ports in an oblong way. But nevertheless, I'm going to align the lens in this oblong fashion so that the claws are exactly under these side port incisions. So I want to be as close to these side port incision as possible. I don't want to create a fresh incision. So let's see how it turns out. I'm going to use the Clayman forceps. Again, as I've explained in my previous videos, the point of holding the lens with the forceps exactly corresponds to the level of the claws in the haptic. The haptic is maneuvered under the iris, it is pushed up against the iris now, and then with a 26G cannula, the iris is tapped down so that it just gets enclaved. The puckering of the iris tissue is a confirmation that the enclavation is done and is proper. Viscoelastic is replenished into the eye, the hands are switched, and again I go in with my forceps and hold in the exact position which would correspond to the position of the claws on the haptic. The haptic is just maneuvered under the iris, then it is pushed up against the iris, then the 26G cannula in my non-dominant hand is used to tap the iris down so that it gets enclaved. I just repeat it once more time, and before leaving it, I just pull the lens sideways to ensure that the iris is also moving along, which is a confirmation that the iris is well and truly enclaved. This was a case where visibility was not good and the side ports were not done in exactly the same position, which I would have preferably liked for an iris claw lens. Nevertheless, we need to make some adjustments. So I'm confirming with the dialer, just trying to push the lens down and see whether it is holding onto the iris well. It looks to be very steady. Before closing, I just want to confirm the absence of any vitreous prolapse during these maneuvers. Diluted triamcinolone acetate is injected into the antechamber and confirms the absence of any vitreous. The antechamber is gently irrigated out and the side ports are hydrated. The conjunctival flap is closed on either side with an aerovicryl suture. That's it, the case is done. So these are the first day post-op pictures and the patient continues to do well. To summarize, could I have prevented the losing of the bag in this case? Probably yes, if I was a little bit careful in making a smaller excess and putting in a CTR at the earlier point. Of course, it's unlikely, but still possible to save the bag. And the second important message here is, if you're certain that vitreous is not disturbed, in rare cases like these, you can still get away without using your vitrector and just placing the lens and using your scissors and the forceps to perform a peripheral iridectomy. So that was it. Thank you for watching and I hope you found this helpful.